CLL in Latin America? How many of these patients are really fit, or the so-called go-go? And how are they treated? As a background information, we must acknowledge that the treatment of CLL patients has improved over the past several decades. Nowadays, the gold standard of upfront treatment of this disease is represented by chemoimmunotherapy. Generally speaking, the so-called fit patients receive rituximab with cytostatic drugs such as fludarabine plus cyclophosphamide or bendamustine. Very recently, the publication of the long-term follow-up of the CLL trial has shown that FCR has held up the test of time. But despite its superiority over FC, it is clear that the IGH unmutated cases, as has been stated before, have a much worse outcome. And also, even the mutated cases have a worse outcome if they do have deletion 17p. Furthermore, the overall superior efficacy of chemoimmunotherapy is counterbalanced by a marked increment in toxicity, as shown in the slide. FCR has approximately 76% chance of producing more than 3+ adverse events. Therefore, in order to adequately treat an individual patient, besides the indication to start treatment of the disease, one needs to consider whether the patient is fit to withstand this type of treatment, and here is when the term go-go emerges. In the US, age is the most commonly used point to define fit or unfit patients, and the cutoff point is between the ages of 65 and 70. And just remember that the median age of diagnosis of these patients is approximately 72 years old. In Europe, they often use the SIRS score or the creatinine clearance to differentiate these two populations. The SIRS score, or cumulative illness rating scale, scores from 0 to 4, 14 different organs with a maximum possible of 56 points, and considers a SIRS above 6 as an unfit patient. Again, it is easy to imagine that most of this elderly population will have several, if not many, of these comorbidities, and I believe that most of the patients are unfit to start with. What about CLL in Latin America? The first point is that there is very little information overall. In Mexico, one of the most prestigious academic centers, the Instituto Nacional de Nutrición, reported a few years ago only 49 cases seen in a 35-year period, with a median age of patients of 63.5 years. And later on, they published of almost 2,000 cases of leukemia, and only 6.6% were CLL. Another important center in Mexico, in Puebla, reported only 9% CLL cases among 211 leukemias that were seen over 15 years, and only, and very interestingly, 8 of those 19 cases were of true Mexican mestizos. In Chile, there is some evidence that the disease seems to be less frequent among the natives and mestizos. And there is a publication from Bolivia that reported only 18 cases of CLL out of 337 adult leukemia cases. And of those 18 cases, 16 patients were above the age of 60. I did a phone survey from several referral centers within the metropolitan area of Mexico that has a population of approximately 30 million people. And it seems, as you can see on the slide, that most of these centers see only a handful of cases per year of CLL, approximately 10 cases. In my center, we have seen 19 patients in the last 13 years. The median age of these patients is 74 years, and only 5 were under the age of 70. Again, as you can see on the slide, only half of them are pure Mexicans, and the others were either foreigners or born in Mexico from European parents. 42% of these patients were unfit according to the SEERS score. Of the 13 patients in whom a FISH analysis was performed, none had the lesion 17, and most of them had good prognostic cytogenetics, sometimes in combination the lesion 13 and trisomy 12. At a median follow-up of 8 years, 37% of our patients have not yet required treatment and are still on the policy of watch and wait. In terms of how we treat patients, there are several reviews of the subject in Mexico, but as the data is very scarce, none has really made a sound recommendation regarding the best way to treat these patients. The only onco-guide published in 2011 from the National Cancer Institute has recommended the watch and wait policy as the first option, and for patients with good performance status and normal renal function, FCR is the first choice. Patients with comorbidities or above the age of 60 or in poor performance status should be treated with chlorambucil. And I must say that most of the patients in my country are basically treated only with chlorambucil. In summary, I think that there is very little information to draw any firm conclusions of this disease in Latin America, at least in Mexico. CLL seems to be less prevalent in native Latin American population, at least in Mexico, Bolivia, and Chile. The age distribution is similar to other series, mostly older people, most of the time unfit to withstand aggressive treatment. In Mexico, in particular, the lack of resources impedes the proper cytogenetic risk assessment and also the institution of the appropriate treatments. Thank you very much for your attention.
Thank you very much. I mean, I didn't realize that there was this, there appears to be a low incidence of CLL in Latin America. Is that, I mean, Ricardo, is that, because I saw you were quoted there, is that Bolivia the same? And so do we, I mean, is this across the board? I mean, it's something I didn't know, but I mean, I know, because I mean, we go to Japan, Hong Kong, China, it's a rare disease. So is this?
It's the same in Ecuador. We see CLL patients 1 to a year, and I don't know why. I think that because the patients don't go to the public hospital, or because they don't make the diagnosis, or because they don't do importance to the disease. I don't know, but it's really.
But you know, that's what came to my mind. But when you showed the data, so the 37% of patients, you just followed them. They didn't have, if they come late, they have aggressive disease. So that was not the case. So that's very interesting then. I mean.
Yeah, I think he's right. I believe that sometimes the diagnosis may not be made. We've seen that many patients that we see have had lymphocytosis for several years, and nobody paid attention to the disease. So it may be an underreporting part of the issue of the low prevalence. But also, I think that there are some genetic basis for it. I mean, in this disease, there are clusters of families with the disease, and we know that in Asian population, as you mentioned, the prevalence is less. And I think that Jorge has published some data that there are differences in genetics in the Mexican population that is similar to the Asian population and not to the more Anglo-Saxon population. And maybe that explains, at least in part also, why the prevalence is low. But the fact, I think that at least in the real mestizos, as we call people who have several generations in the country, the prevalence of this disease is much lower than in other parts of the world.
And in Argentina?
I think
I
we
think
cannot
looking at-
say.
Ladies first.
Oh, yes.
No, I will just comment a little bit on this. I think it might be a combination because if you look at the data from the developed world, the diagnoses are made in early stage CLL, and as the years go by, we have more diagnoses in early stage, and that is, with flow cytometry in peripheral blood, and that might not be done in every patient with lymphocytosis in Latin America. So I believe, I don't know, but I believe there is an underdiagnosis as well. Maybe there is less incidence, but surely an underdiagnosis compared to very early stages diagnosis in developed world. And regarding your question, Buenos Aires is maybe not the same as the rest of Argentina. We do diagnosis in early stage with flow cytometry in peripheral blood, so we have a high incidence as well.
You're European.
May I comment on the...
But I think the problem we have in Argentina, as far as I know, is the quality of data, first of all. So we don't know exactly what we have and what we have to face in our country because we don't have good data regarding the epidemiological studies of the actual incidence of these diseases. So to be honest, we really don't know. We believe that in this, as Astrid says, mainly European population of the Buenos Aires area, we think that we have a similar incidence of CLL than in the rest of the developed world. But we don't know what happens with special native populations in our country. Data are scarce and with no good quality.
Yeah.
Can I comment on that? For example, in my institution in Mexico, social security system, we receive almost 450 lymphoma patients newly diagnosed per year, 100 acute leukemias, and only 10 cases of CLL. So we perform a multinational study in almost 200 patients in different zones of the country, and was published last year in British Journal of Hematology, and looking for polymorphism in true mestizos patients. So we exclude patients with 3 generations before an antecedent of European or Anglo-Saxon origin. So in true mestizos, we found some how to say, genetic factors common with Chinese or Asian people. And for example, I think this is very common in all Latin American countries, with the exception of Argentina and Uruguay. Those people have European genes, and the prevalence is almost the same as in Europe. So this is published in British Journal. It's very interesting. 2 polymorphisms, very increased incidence, the same as Asian people.
Right.
We have a study in Ecuador where demonstrated that most of the population from selvas and very high country, they have the same genetic aspects. more with the Asian aspect than the European aspect.
I remember
But,
going to Brazil, and there was somebody suggesting that because Brazil is an ideal setting of, let's say, the origin, some coming from Africa and some not, and the groups coming from Africa, I remember vaguely that CLL seems rare. Or no, I remember wrong.
We don't have this data. May I say some? We have a registry, a Brazilian registry, account with 1,200 patients. Let me tell something that we have. We don't have a registry population based, so we don't have the incidence of this disease. Seems to be, as in Argentina, similar to other Occidental countries, but we don't have this data. What it's interesting, as you know, we have data from 22 centers in Brazil. We have 5 different regions, social and economic different regions. We don't have data from the poorest region, the north part. Most of the patients are the Sudeste, 73%. And related to the age, patients over 75 years, we have just 24%. When you compare this with SEERS, SEERS shows 41%. So we have a lower age. The median age is 66, and related to the ethnicity, as you said, 70% of our patients are European descendants, and just 6% are African descendant, 1% Asian descendant, and 24% mestizos. What called our attention, as it's very important to show up, is the very, very heterogeneity, how these patients were treated in different regions in Brazil. In some part, for instance, the patients are treated just after the diagnosis without criteria to start, conventional criteria to start these patients. So this is a paper that is just submitted to our Brazilian journal, and is the first analysis of this data.
Thank you.
Robin, I think CLL incidence depend of expectative life, because in Bolivia the CLL incidence is decreased because the expectative life is 65 years.
Yeah, sure. Yeah, obviously that is a key point, clearly. But I think it's come out something that I didn't know about, the fact that in some parts this could be a difference in incidence.
Yeah,
Paolo, and then
I
we
make
have
just a
two
quick
more.
comment. I was also surprised. It is definitely a take-home message from this meeting. At the end, on a second thought, I'm not so surprised, because I've been studying geography and history with my kid who is attending the second middle school. Second year
So
middle
you
school.
study
And
with your
indeed,
kid. That's the other message. So you do homework with your kid.
No, I study with him, because he comes and repeats me, "Oh, Daddy, I heard this," and I learn a lot of things. And I learned even the Indios here. They came originally from Asia through the Bering Sea, and they went down to Patagonia, even, which I didn't know.
Yes.
Amazing. So it is true. It's a different type of population. So we don't have to consider the African or the European coming to Latin America, because this is completely different genetically. And I think what we could do, and this could be a good place where to organize this, there is one way to really understand if this is true or not, by studying MBL, so monoclonal B-cell lymphocytosis. We did that in Far East, in Taiwan. So, because the question is always, is CLL misdiagnosed, underdiagnosed, or whatever? So you just screen 200, 500 people for the presence of MBL. If the MBL frequency is low, it means that also CLL will be low. If it is high, that it's a problem of diagnosis. And that's what happened in Taiwan. The frequency of CLL is low, the frequency of MBL is virtually undetectable.